Hello, today we will start our discussion of viral hepatitis. Today will be the first part, as you see, and the next lecture we will have the second part. Today we will speak in general about all hepatitis and hepatitis A and E, yes, like fecal oral hepatitis with fecal oral mechanism of transmission. Our next lecture we will speak about the parenteral, so-called parenteral hepatitis B, C, and maybe some another like D and G. Okay, let's start. We will start exactly from such moments like from the very beginning, from anatomy and physiology and functioning of the liver, because it's one of the most important organs in our in our organism, in our body. Yes, and that's why I think the repeating will be very good for our lecture and for the beginning of understanding the influences of viral hepatitis and what they can cause if we'll decrease the functioning of liver and so on. Now some short like schematical movies, like cartoon movies, something like that, about the anatomy and physiology of liver.
Armando Hasurigan, biology and other organs such as the gallbladder, which is under it, and the stomach, which is to the left of it. The liver is about 1.2 to 1.6 kilograms in healthy adults. It is located in the right side of the body under the lower ribs. The liver can be seen as though it's made out of two major lobes, but it's actually four lobes of unequal size. Now, the organs that are in close proximity to the liver is a gallbladder, which actually connects with the liver. The bile duct comes from the liver and the gallbladder, and the cystic duct coming from the liver. And these are important in the bile system, which we'll look into later on. The liver actually has a lot of blood supply in order to be oxygenated and in order to receive nutrients. So two important things, oxygen and nutrients. So if we look at the liver's blood supply, here we have the artery, the aorta coming from the heart, which brings oxygenated blood into tissues, body tissues. So here there's just capillaries of general circulations where the tissues will then use up the oxygen, and now this blood supply will be deoxygenated. It will be low in oxygen concentration. And this deoxygenated blood supply will go back to the heart through the inferior vena cava. Now, organs found on the bottom half of our body are the liver, stomach, spleen, and also intestines. The aorta coming from the heart gives oxygenated blood to all these organs, the liver, stomach, and the intestines. The artery going into the liver is known as the hepatic artery, and this gives the liver oxygenated blood. It gives the liver oxygen to function. The artery giving oxygen to intestines is known as the mesenteric artery, and we won't really focus on this. Now, what's important to know is that once the spleen, stomach, and intestine has used the oxygen from the blood supply will be deoxygenated. And this deoxygenated blood supply will be veins. And actually, this vein will not go back to the heart, but will go towards the liver as a big vein known as the portal vein. And these veins carry nutrients from the stomach, spleen, and the intestines. And that is how the liver receives nutrients. So we see that we have the hepatic artery and we have the portal vein, one of them bringing in oxygen and the other bringing in nutrients. And then the liver, once it's used all these oxygen and nutrients, there will be another vein leaving the liver known as the hepatic vein, which connects to the inferior vena cava, which then goes back to the heart. So let's look at this diagram in a bit more complex detail by looking specifically at the liver. So here we have the liver. The aorta brings in oxygenated blood to the liver through the left and right hepatic artery. So again, this is oxygen-rich blood from the heart. And this actually only supplies about 25% of the blood supply to the liver. And then we have the vein leaving the liver towards the heart. And this is the right hepatic vein, middle hepatic vein, and the left hepatic vein, which connects to the inferior vena cava, which then goes back to the heart. And then we have the portal vein, which brings in nutrients. And this comes from the intestines. And this is about 75% of the blood supply going to the liver. So it's much more than the oxygen supply from the hepatic artery. So again, the portal vein brings in nutrients from the intestines, spleen, and the stomach. And then remember, we also have the gallbladder here, which connects to the liver. And this stores bile for secretion. And we have many bile ducts within the liver because of this connection. Now let's have a look at how the hepatic cells are organized within the liver and how the blood supply with oxygen coming in, the portal vein with nutrients coming in, and the hepatic vein leaving the liver all connect together and coincide within this organized structure. Well, the liver is organized in a hexagonal sort of shape known as a lobule, like so. Each lobule here contains many types of hepatic cells, liver cells. In the center of the lobule, we have the central vein, which essentially connects to the hepatic vein, which leaves the liver towards the heart. And all these blue things coming out of the hepatic vein is the liver sinusoids. And they run from the central vein into the portal triads. So they connect with the portal triads. What is the portal triads? Well, the portal triads consist of three things: the portal vein, the bile duct, and the hepatic artery. And so all these veins connect with each other, and all these three connect with the central vein. And this is how the liver receives its oxygen, receives its nutrients, and how it sends out bile from the liver into the bile duct. So again, this is known as a triad. Hope this all makes sense. Now, it's also important to note that the liver contains special macrophages, hepatic macrophages, known as Kupffer cells. I hope I pronounced that right. Let's have a look at this section here and look at the organization in a better diagram. So here what I'm drawing is the hepatic vein, essentially the central vein. And here we have the sinusoids, which remember connects to the portal triads. And the portal triads here are the bile duct, a branch of the hepatic portal vein, and the branch of a hepatic artery. So bile duct, portal vein, hepatic artery. And surrounding all these sinusoids and all just everywhere are the hepatic cells, known as hepatocytes. And so whatever comes through the portal vein and from the hepatic artery can be given into these hepatocytes and then will be emptied out into the hepatic vein, which will then enter the heart. Similarly, cells which produce bile can then give it to the bile duct, which then goes into the gallbladder. So I hope that makes sense. And remember that we have the macrophage, the liver macrophages known as Kupffer cells. And these are important in the immune system. Lastly, as I mentioned, the organization inside the liver are hexagonal shaped lobules, with the central vein being in the middle. The central vein can be also referred to as a hepatic vein because it essentially goes back towards the heart. And then surrounding each corner of the hexagon, we have the portal triads. And if you remember what the portal triads are, they are the portal vein, the hepatic artery, and the bile duct. And they connect essentially to the central vein. And with this connection, the portal vein can then give nutrients to the hepatocytes, and the hepatic artery can give oxygen to the hepatocytes as well around here. So I hope this was an enjoyable video.
Так, and also another one about the physiology. It's a little more complicated, yes, but physiology is physiology. About functions of the liver and
Armando Hasurungan, Biology and Medicine. Amino acids. Functions of the liver, liver physiology. The liver has many, many functions. Let's look at them one by one. First of all, it can synthesize amino acids. one of the processes is called transamination, where we have an alpha keto acid, which is an alpha carbon with a keto group and a carboxyl group, which can get converted into an alpha amino acid, where the alpha carbon has an amino group and a carboxyl group. Now, the process, as I mentioned, is known as transamination, and the enzyme used is usually known as transaminase or aminotransferase. So let's look at one example. One example is if we have glutamic acid here, plus pyruvic acid, with one enzyme will yield alpha keto glutamic acid and also alanine. Alanine is the amino acid, where the amino group is transferred from the glutamic acid into the pyruvic acid, making alanine. The enzyme used is known as alanine transaminase, or ALT. Note the transaminase. The liver can also metabolize amino acid. A process known as oxidative deamination essentially deaminates a molecule, removes an amine group, which is NH3 or 2. Because it is an oxidation process, the molecule itself is oxidized, and so hydrogen is removed. Let's look at an example. Let's say we have L-glutamic acid here with the amino group, and this will be oxidized to a molecule and then be hydrated again. When it gets hydrated, the previously L-glutamic acid will liberate an ammonia group. This ammonia group left the L-glutamic acid, and so this process is known as deamination because the amine group left. Ammonia is important later on because it can enter the urea cycle. We will look at it later on though. But first, another function the liver possesses is that it can synthesize proteins. It can synthesize many, many proteins. One of the most important proteins is albumin. Actually, 50% of the total protein the liver synthesizes is albumin. Albumin helps in maintaining the osmolarity and also the transportation of various hormones. The liver also synthesizes proteins for the immune system, such as the C-reactive protein, opsonin, which helps for opsonization of a pathogen, and also it synthesizes plasma complement proteins, C1 to C9. Complement proteins are important for destroying a invading pathogen. The liver also synthesizes various hormones and prohormones, such as insulin-like growth factor, IGF, not ILGF, sorry, it's IGF. IGF is important for growth and also has anabolic effects. The liver also produces thrombopoietin, which is important in platelet production. Platelets is important for hemostasis, for fixing up blood vessels. The liver also produces another hormone known as angiotensinogen. Angiotensinogen is part of a big system known as a renin-angiotensin-aldosterone system. This system helps regulate blood pressure. The liver also synthesizes proteins that are clotting factors and inhibitors of coagulation, so anticoagulants. These are prothrombin, fibrinogen, and also antithrombin and alpha-2 microglobulin. Prothrombin and fibrinogen you may have heard from hemostasis in the repair of a damaged blood vessel, for example. Now, the liver also synthesizes plasma proteins that are or carrier proteins that help carry substances or molecules from A to B, such as from the liver to the kidney, or from the liver to the muscle, for example. So these are carrier proteins. An example of carrier proteins is transferrin. Transferrin carries iron ions in the ferric acid forms, Fe3+. So transferrin carries iron atom ions around the body. Another one, carrier protein, is IGF, insulin-like growth factor binding protein. And this carries insulin-like growth factor 1, which, if you remember, is also produced by the liver. And if you remember, insulin-like growth factor 1 is important for growth and development. Now, finally, we can go back to another function the liver does is urea, the production of urea. So the liver produces urea. What is urea? Well, let's just draw the liver here. So just recapping, we know that amino acids can can be made into proteins, can synthesize proteins. It can synthesize plasma proteins. Plasma proteins such as transferrin and insulin-like growth factor carrier protein, which are both carrier proteins. They carry proteins from A to B around the body. Amino acids can also be enter into conversion, so it can become a pyruvate or it can become another sort of molecule, but not amino acids. Alternatively, amino acids can follow deamination, removal of the ammonia group, and so we have an accumulation of ammonia. Nucleic acids can also be metabolized to give off ammonia. So what happens with this ammonia? Well, ammonia, NH3, can enter the urea cycle, what's called the urea cycle, to produce urea. Urea will then get expelled by the body. And this is how amine groups gets expelled. NH groups get expelled from the body through urea, and they're usually excreted in urine. So they go to the kidneys. Now, possibly, well, one of the most important functions the liver has is the production of bile. So bile production. So the liver actually produces bile and secretes the bile where it gets stored in the gallbladder. The gallbladder is right underneath the liver and looks something like this. And then we have a common bile duct where the gallbladder can essentially excrete or secrete out the bile into the intestines to help digest fats. So let's look at this in a different diagram. Here we have the intestines and we have the pancreas right next to the intestines, the small intestines, this is. The gallbladder is situated here, and it essentially secretes its substances through the common bile duct, which enters the intestines over here. The gallbladder stores bile. So what happens is, when we eat fatty foods will get digested by the stomach, will enter the small intestines, and will stimulate the small intestines to secrete a hormone known as CCK, because the intestines cannot absorb these fatty substances just like that. It needs the help of bile. So it secretes the hormone CCK, which will then stimulate the gallbladder to contract, to then release the bile into the small intestines and to help emulsify the fats, cover the fats, so that the fats can be easily digested and absorbed by the small intestines. Now, bile is made up of two main things. It's made up of bile acids or salts and also bile pigments. So bile acids and bile pigments. Let's firstly look at bile acids. Bile acids are amphiphilic steroids, and they emulsify ingested fats so that the fats can be easily digested and absorbed by the small intestines. Bile acids are amphiphilic steroids. What does this mean? Well, it means that if this was a bile acid, it would have one side which is hydrophilic, which means it loves water, and the other side which is hydrophobic, which means that it hates water. So what does this mean? Well, when we consume the lipid and when it's in the small intestines, the bile acids will begin surrounding it, where the hydrophobic regions will essentially cover the lipid and the hydrophilic regions will face the outside, because the hydrophobic regions are scared of water and so they face inwards, whereas the hydrophilic region will face outwards. And they will cover this lipid, essentially emulsify it, and create what's called a Michelis, I don't know really how to pronounce it, but essentially once they coat this lipid, this can get easily digested and absorbed by the small intestines. So some types of bile acids include cholic acid, taurocolic acid, and deoxycholic acid. Those are some type of bile acids and bile salts. So that was bile acids. Bile acids help emulsify fat. Bile pigments are different to bile acids, but they are also bile altogether. Bile pigments are actually the breakdown products of hemoglobin. Hemoglobin are the centers of the red blood cell. So they're the breakdown products of hemoglobin, and these breakdown products, these bile pigments, will then be excreted out in feces, and that is why we have the brown color in our feces. So what do I mean by this? So in the blood, if there's extravascular or intravascular hemolysis, meaning destruction of red blood cells, The outcome of this would be unconjugated bilirubin, which is the product of destruction of red blood cells. These unconjugated bilirubin will travel through the bloodstream bound to albumin, which will then take it to the liver, the hepatocytes of the liver. So here we have now unconjugated bilirubin without the albumin. Unconjugated bilirubin will then be changed to conjugated bilirubin in the liver. Conjugated bilirubin is the bile pigment because it is the product of breakdown of hemoglobin. So this bile pigment, this conjugated bilirubin, will then travel through the biliary system, through the bile duct, into the intestines. It gets secreted into the intestines. The conjugated bilirubin will then convert to urobinogen through bacterial proteolysis. About 90% of the urobinogen will actually be excreted as feces. So 90% of the bile pigments will be excreted as feces, this urobinogen. So what happens to the other 10%? Well, the other 10% will be reabsorbed through the portal vein, where it will then enter back into the liver, if you know what the portal vein is. So this urobinogen will then be in the liver and will then travel back into the bloodstream towards the kidneys, where this 10% of urobinogen will be excreted as urine. So essentially, bile has two things, is made up of two things: bile acids or bile salts, and also bile pigments. So bile acids and bile pigments. Bile acids are to help in digestion of fat. Bile pigments are the breakdown products of red blood cells, like urobinogen or conjugated bilirubin, which then gets excreted by the body as feces, mainly. Hope that all makes sense. Now, the other function the liver does is that it also performs carbohydrate metabolism. Very important. You can also watch this on my biochemistry videos, but we'll just look at it at an overall picture here. So the liver has a major role in controlling carbohydrate metabolism, and so blood glucose levels as well. So for example, after we eat, glucose will get absorbed by the liver, where it'll get converted to glucose 6-phosphate, then glucose 1-phosphate, and then UDP glucose, and then it will get converted to glycogen. This whole process is known as glycogenesis, the synthesis of glycogen. So glycogenesis would happen if blood glucose levels are high. If blood glucose levels are low, glycogen will be broken down to bits of glucose 1-phosphate, which will then convert to glucose 6-phosphate, and then to glucose. So then glucose can be released into the blood to increase blood glucose levels. And this process is called glycogenolysis. Also, glucose can convert through a series of reactions to pyruvate and produce ATP in the reaction. If blood glucose levels are low and glycogen levels are low as well, amino acids and also fats, for example, can be converted to pyruvate, which then will go through a process known as gluconeogenesis to produce more glucose. The opposite of gluconeogenesis is glycolysis. So I hope you can see from this diagram that the liver not only has many functions such as producing bile, but also in carbohydrate metabolism, as well as other macromolecules, such as lipid metabolism. The liver actually produces a lot of lipoproteins. Lipoproteins, as the name suggests, is lipids and proteins, but mainly lipids, which travel around the body, transporting lipids and proteins. The liver also synthesizes cholesterol and phospholipids. Phospholipids are the main part of lipoproteins. Phospholipids essentially make up most of the cell membranes we have. Cholesterol is important for the body in many respects. If there's too much cholesterol, however, the body will secrete it, either in bile or cholesterol will be converted into bile acids because they have similar structure. And then this will be secreted in the intestines and be excreted as feces. I hope this video made sense. Thank you.
I also hope that you understand, and if we will have the inflammation of liver, all those functions will be under the attack, and that's why so many different symptoms, syndromes, signs of viral hepatitis can be present that we even cannot maybe remember about all of them, but we will try and we will divide them, all this clinical manifestation, into the syndromes, and later we will discuss, and I will try to show everything that I can show you for you and explain everything. Maybe we will have possibility to understand all these influences. Okay, now what is hepatitis? Hepatitis in plural will be, you see, hepatiditis, from ancient Greek word hepar or hepato, meaning liver, and suffix itis. Itis meaning what? Inflammation. I hope you remember. It's inflammation of liver. Yes, it's an inflammation of liver. The condition can be self-limiting or can progress to fibrosis, scarring, in other words, cirrhosis, and even to liver cancer. Hepatitis viruses are the most common cause of hepatitis, viral hepatitis, in the world. But other infections, toxic substances, for example, alcohol, certain drugs, and autoimmune diseases can also cause hepatitis. But viral hepatitis, hepatitis viruses, the most common influence. And now we will start to speak about exactly the main hepatic viruses, the main cause of viral hepatitis. 5 main, yes, present in others, and we will remember about them, but the main will be 5. A, B, C, D, and E. These 5 types are of greatest concern because of the burden of illness and death they cause and the potential for outbreaks and epidemic spread. A, the most common epidemic spreading, even can be very big epidemics can cause. In particular, type B and C can lead to chronic disease in hundreds of millions of people, and together are the most common cause of liver cirrhosis and cancer, B and C. Some words about the historical moments. Let's remember. First was A hepatitis, and it was like the one of the most spreading in the our past times, and it's one that firstly was called like infectious hepatitis, infectious inflammation of liver. It was about the hepatitis A, and maybe you heard about the Botkin's disease, but Botkin disease, it's exactly about the hepatitis A, but a lot of another present. Then were discovered like the serum hepatitis. Serum, why? Because it was exactly researched and investigated from blood, and it was like B hepatitis, no, and also corresponding D, because D cannot be without B. Then was some situations that also was present the hepatitis, but not A, not B. And what does it mean? Till the 80s of 20th century, nobody knows that C also present. No, E, like fecal oral mechanism of transmission. And also, it's not the last C, yes? F can be not confirmed, okay, but some moments present that we can remember that another hepatitis present. G, it's proved, it really exists, G hepatitis, TTV virus, SEN-V virus, and how many such hepatitis can be, we even cannot imagine. Oh, okay, yes, we have to understand that all these hepatitis like G, TTV, CNV, they are more character for such persons that need often blood transfusion, hemodialysis, and so on. Such persons can have, and exactly in these persons were found such hepatitis, such viruses. But the possibility of different mutations present, and don't forget about such possibilities. Epidemiology, mode of transmission. On this slide you can see the prevalence for each hepatitis. What fecal-oral mechanism of transmission? For such mechanism, the most character, such mechanism of transmission, character just for hepatitis A and E in our situation. Sexual transmission, no character for hepatitis B. Yes, the most, you see, 3+. For D also, because it's like going with B. For C also, but it's not very high possibility. Parenteral transmission, the very best will be for B and for C. Yes, it's the most often mechanism, here the way of transmission. For D, G, TTV, what also such possibility, and as a rule only such possibility like parenteral, from blood to blood. And perinatal transmission character, you see for B, it's all. No, we have to remember that for B hepatitis, yes, it's really possible situation as for HIV. Don't forget that all pregnant women have been investigated and like making the analysis on hepatitis B, no, and HIV. B and C, the best situation, yes. And for hepatitis C and D, it's not so often, but also sometimes possible. Periods of the disease, what can be? Prodromal, you have to remember, yes, about the prodromal period. Sure, the clinical manifestations, the climax of the disease during the jaundice period, no, and period of convalescence, and as a rule, the producing of immunity, but not development of immunity, but not for all hepatitis, and some peculiarities present. That's why we will discuss later about this. Acute infection. Acute infection with hepatitis virus may result in conditions ranging from subclinical disease or self-limited symptomatic disease to fulminant hepatic failure. And it's really possible. And nobody knows why such duration can be, maybe due to the disease situation, like premorbid state of the patient, and maybe already like involvement of the liver before the acute hepatitis, maybe due to this. But yes, fulminant hepatic failure, and I saw such cases that even young adults died exactly even under the influence of hepatitis, especially B. Adults with acute hepatitis A or B disease are usually symptomatic. Remember, because as a rule for children, hepatitis A will be like just fecal intestinal infection. B, yes, B, it will be also dangerous. Persons with acute hepatitis C maybe is symptomatic or asymptomatic or subclinical, in other words, and as a rule, maybe you also hear such definition like silent killer. It's about exactly hepatitis C, because as a rule, nobody mentioned acute form of the disease, only in chronic state or even already in the period of cirrhosis. That's why it's like very silent duration of the disease, but leading to very serious complication, hepatitis C. Symptoms of acute, like prodromal periods of the viral hepatitis. What can be? Prodromal period will be about 3-4 days. Will be like flu-like syndrome, fever, fatigue, anorexia, nausea, and sometimes vomiting can be, diarrhea can be. Discomfort in the upper right of the abdomen due to the liver enlargement. It's not like the pain of the liver. Liver doesn't have the sensitive endings. That's why it cannot be painful. But the capsule of the liver, yes, it can. And during the enlargement of the liver, the capsule will like make such feelings like painful. Occasionally, especially during hepatitis B, infected person develop joint pain, and it's due to the mesenchymal inflammatory syndrome and such red rash on the skin. And it already has the name by Orse Gianotti-Crosty syndrome, like papillose dermatitis, you see. Such types of prodromal period can be, and it's interesting why, because we have to differentiate viral hepatitis exactly what's with such diseases like flu-like. That's why we have to, in the prodromal period, sure, we have to differentiate with flu. Yes, with flu, with all another acute respiratory viral diseases like COVID, even maybe to for now time, for our times. Dyspeptic can be, what you see, yes, during flu can be fever, even sore throat, can be cough or running nose. It's like flu-like symptoms will be during the prodromal period. What does it mean, prodromal? Before the real clinical manifestation of the disease. For example, this jaundice and all these inflammations that we will speak a little later. Also can be dyspeptic prodromal period. What does it mean? Can be anorexia, nausea, and sometimes vomiting, diarrhea even. We have to differentiate with all intestinal infections. Yes, I understand that hepatitis A and E like also intestinal infections, but they influence on liver, not only on the intestine. That's why we will differentiate with intestinal infections. Arthralgic. More character for B hepatitis, but can be during all hepatitis in prodromal period. Arthralgic, and it will lead to what? To the differential diagnosis with all possible rheumatological diseases and so on, even sometimes traumas. Astenovegetative, no, yes, it's the best syndrome for all students because they start only from astenovegetative syndrome. But during hepatitis, yes, you can start from astenovegetative because it's really very serious astenovegetative syndrome. Fatigue, like person cannot stand up from bed. Dizziness, so high weakness that even cannot go into the toilet. No, and sure, yes, can be mixed of all these possible prodromal periods. No, and after prodromal period will come the jaundice period, the period of climax of the clinical signs, and what jaundice period. Urine becomes dark and stool be like hypocolic, decolorized. It will not be white or gray, no, it will be yellow, like light yellow, but not brown. Jaundice, a yellowish discoloration of the skin, mucus, and eyes. Bilirubin elevation, it's mean in already in the biochemical blood analysis. Both of the symptoms occur because bilirubin rises in the blood, jaundice and bilirubin elevation both in the blood, mainly due to the direct fraction, but at the beginning of the disease, when the liver will be very seriously involved, also the indirect can be unconjugated. At hepatitis A with the jaundice, the most symptoms usually began to regress. Remember, during hepatitis A with jaundice, the state of the person will become better and better. And remember that in 5 days of jaundice, as a rule, the discharging of virus during hepatitis A, don't forget, only A, not all another. The discharging of virus stop, and such persons already not dangerous for surrounding. But such persons have to stay because we don't know exactly when can be some relapses or something like that. So they have to stay in hospital. And people feel better even though the jaundice may worsen during hepatitis A. For B, C, and other hepatitis, it's not true. The jaundice usually peaks in 1 to 2 weeks, then fades over to 4 weeks. Some words about the jaundice in movie, short movie.
Jaundice, which doesn't have the most intuitive name, comes from the French jaunisse, meaning yellowing. It's also sometimes referred to as icterus, though, the origin of which is even less intuitive, coming from the thought that jaundice could once be cured by looking at a yellow bird. Well, the more you know, right? Anyways, as you've probably gathered, jaundice involves someone taking on yellow pigments, specifically in the skin and eyes. The yellowing pigment is caused by a compound called bilirubin, a component of bile and the main cause of bruises being yellow, and after its metabolism, the yellowness of urine and brownness of feces. So since bilirubin's our main culprit of yellowness, it's super important to know where it comes from. As red blood cells near the end of their lifespan, which is about 120 days, they're eaten up or phagocytized by macrophages in the reticuloendothelial system, aka the macrophage system, where the spleen plays the largest part, but it's also made of parts of the lymph nodes. Okay, so first the macrophage eats up the blood cell, and hemoglobin is broken up into heme and globin. The globin is further broken into amino acids. The heme, on the other hand, is split into iron and protoporphyrin. Protoporphyrin is then converted into unconjugated bilirubin, or UCB for short. Unconjugated bilirubin is the form of bilirubin that's lipid-soluble, meaning it's not water-soluble, right? Albumin in the blood then binds to unconjugated bilirubin and gives it a lift over to the liver, where it's taken up by hepatocytes and eventually conjugated by an enzyme called uridine glucuronyl transferase, or UGT, making it now water-soluble. At this point, the conjugated bilirubin is secreted out into the bile caniculi, where it drains into the bile ducts and is sent to the gallbladder for storage as bile. Now, when you eat a donut or something, your gallbladder secretes the bile, which has the conjugated bilirubin in it, and it moves through the common bile duct to the duodenum, the small intestine, and is converted into urobilinogen, or UBG, by intestinal microbes in the gut. Now it undergoes spontaneous oxidation and turns into urobilin, which is excreted and responsible for the brown color of feces. About 20% of that urobilinogen is actually recycled, though. In other words, it doesn't get oxidized and instead gets reabsorbed into the blood and gets sent over to the liver and the kidneys. About 90% of it goes to the liver and 10% goes to the kidneys. That 10% that goes to the kidneys is excreted and causes the yellowness of urine. And there you have it, bilirubin metabolism in a nutshell. Now, if some point in this process gets disrupted, for example, if your liver cells are damaged and can't conjugate bilirubin anymore, or maybe if they die off and release their bilirubin, you can end up with increased bilirubin in the blood, which can be either conjugated or unconjugated, or both. And this is what accounts for the yellow color in the skin and the eyes. Usually it takes about 2.5 milligrams per deciliter, or greater, of serum bilirubin to give the skin that Simpsons-esque yellow skin tone. The earliest sign of jaundice and increased bilirubin in the blood is this yellowing of the sclera of the eyes. Scleral tissue is high in elastin, which has particular fondness for bilirubin and binds it with a very high affinity, giving that scleral tissue in the eyes a yellow color often before the skin. Now, as you might imagine, after looking at this process, there are quite a few potential pitfalls along the way that can lead to jaundice. And they're lumped together depending on whether they have more unconjugated bilirubin in the blood, or more conjugated bilirubin in the blood, or more of both in the blood. Two types of disorders that have increased unconjugated bilirubin and similar presentations of jaundice are extravascular hemolytic anemias, where red blood cells are broken down earlier than they normally would be, and ineffective hematopoiesis, where your blood cells don't form quite right in your bone marrow, causing macrophages to break them down. In both cases, the red blood cells are broken down, right? Causing high levels of unconjugated bilirubin. Since your hepatocytes can only work so hard converting unconjugated bilirubin to conjugated bilirubin, they can get overwhelmed. As an imaginary example, say that this liver cell can conjugate 10 molecules of unconjugated bilirubin per minute, max. But normally they only see 5, so that's easy. If all of a sudden your body starts breaking down more red blood cells, and the unconjugated bilirubin molecules on this cell's docket jumps to 15 per minute, this liver cell cannot keep up. And that excess of 5 molecules of unconjugated bilirubin stays in the blood, right? And that's only the first issue. In addition, as the liver cells max out, now there's all this conjugated bilirubin that goes into the bile, which increases the risk for pigmented bilirubin gallstones. Not only that, once all that conjugated bilirubin is sent to the duodenum, it's converted to urobilinogen. Remember that 20% of that urobilinogen is recycled back into the blood, and some of it is excreted into the urine, giving it a much darker color. But the unconjugated bilirubin is not excreted because it's not water-soluble. In the previous two cases, too much unconjugated bilirubin was created. But you can also have hepatocytes that just can't work hard enough and keep up with a normal load. Physiologic jaundice of the newborn is one of these cases. Newborn livers have a lower amount of the enzyme UGT in the liver to convert unconjugated bilirubin. And after birth, unconjugated bilirubin levels can be high due to the natural process of macrophages destroying fetal red blood cells. Typically, this is normal, but there can be complications if unconjugated bilirubin rises a lot. Since it's fat-soluble, it can collect in the basal ganglia of the brain, which is also called kernicterus, and cause damage to the brain or death. Treatment of this condition is usually phototherapy, which uses light to induce structural and configurational changes in the bilirubin molecule. Basically, it absorbs the energy from the light and changes shape. And these new shapes are more soluble and can be excreted in the urine. And this can be a super effective and non-invasive way to get excess unconjugated bilirubin out of the blood. Another potential case where not enough unconjugated bilirubin can be conjugated is through hereditary defects. One case is called Gilbert's syndrome, where the UGT enzyme activity is low and has a hard time cranking up when needed. So maybe this liver cell can only pump through a max of 6 molecules per minute. Unfortunately, if something comes along that increases hemolysis, like infection, stress, or starvation even, the unconjugated bilirubin load will increase, which can easily overwhelm these hepatocytes, cause buildup of unconjugated bilirubin in the blood, and lead to jaundice. Another genetic example is called Crigler-Najjar syndrome, where Gilbert's syndrome was a low amount of UGT enzyme. Crigler-Najjar is where there's pretty much no UGT enzyme at all, and therefore no ability to conjugate the unconjugated bilirubin. And this will lead to super high levels of unconjugated bilirubin in the blood, and likely lead it to being deposited in the brain and cause kernicterus. For this reason, Crigler-Najjar syndrome is usually fatal. All right, so the previous couple examples focused on high levels of unconjugated bilirubin in the blood, but there are also examples of jaundice with high levels of conjugated bilirubin in the blood. Dubin-Johnson syndrome is an autosomal recessive disorder where there's a deficiency in the protein that helps move conjugated bilirubin from the liver cells to the bile ducts, called MRP2. So the conjugated bilirubin builds up in the hepatocyte since it can't go anywhere. It's thought that when the MRP2 transporter is defective, another transporter, MRP3, is upregulated. This transporter is different, though, in that it moves it to the interstitial space and the blood flow, as opposed to the bile caniculus. So in this case, you'll have increased conjugated bilirubin in the blood, which also gets excreted into the urine, giving it a darker color. And this also causes the liver itself to get very dark. Another high conjugated bilirubin category of jaundice is called obstructive jaundice. And this is basically where something blocks the flow of bile. And these blockages could be anything from gallstones, pancreatic carcinomas, and cholangiocarcinomas to parasites like the liver fluke. Remember that bile is made up of conjugated bilirubin, and this blockage basically causes pressures to rise in the bile ducts, which literally causes bile to leak through the tight junctions between hepatocytes that line the walls of the bile ducts. But that's not the only thing that leaks out though, right? Bile salts, bile acids, and cholesterol can all get into the blood. If they deposit into the skin, it can lead to itchiness or pruritus, but also lead to things like hypercholesterolemia and xanthomas. That excess conjugated bilirubin is excreted in the urine since it's water-soluble, which again leads to dark urine. Also, since you're losing a lot of bile, you won't be able to absorb fat as well, which, 1, causes you to excrete a ton of fat, a condition called steatorrhea, and 2, causes you to not be able to absorb as many fat-soluble vitamins as you need. Finally, viral hepatitis leads to both conjugated and unconjugated bilirubin in the blood. When hepatocytes get infected and start to die off, they both lose the ability to conjugate bilirubin, leading to excess unconjugated bilirubin in the blood. And since they also line the bile ducts, when they die, they let bile leak into the blood, causing an increase in blood conjugated bilirubin as well. Again, since conjugated bilirubin is up, patients will have more conjugated bilirubin excreted and darker urine.
Well, I hope you understand a little from this metabolism of bilirubin, and that's why you can understand that, like, killing and destroying the hepatocyte can lead not only to the unconjugated bilirubin increasing, but also conjugated. Why? Because exactly liver try to conjugate all this indirect or unconjugated bilirubin, but it's already like injured, and that's why cannot conjugate everything, and it will lead to increasing as unconjugated as conjugated. It's try but cannot conjugate everything. No, and it will lead, during viral hepatitis, it will not be such a colic stool, but it's example of this colic stool. Dark urine, what you see, what will be, yes, it's normal. It's like, can be like Coca-Cola, or like strong tea, or we even sometimes say like dark beer. And what is choluria is the presence of bile pigments, better to say, in urine. What else will be? What another enzymes and signs can show us that exactly viral hepatitis, the inflammation of liver present, not some another, like exactly parenchymal jaundice present, not obstructive or hemolytic jaundice. Alanine aminotransferase, one of the enzymes, very important enzymes for liver, yes. As I hope you remember from the video about physiology. Alanine transaminase is a transaminase enzyme, yes. It is also called alanine aminotransferase. is found in serum and in various bodily tissues, but most commonly associated with liver alanine aminotransferase. Now let's start speaking exactly about the clinical and laboratory manifestation of viral hepatitis, and we try to divide all the symptoms into syndromes, and what such a lot of different syndromes can be, no, and you understand that even more and more symptoms that we try to like conjugate, yes, connect and put in one of all the syndromes. Cytolytic syndrome, syndrome of hepatocellular insufficiency, mesenchymal inflammatory syndrome, cholestatic syndrome, astenovegetative syndrome, dyspeptic syndrome also, hemorrhagic syndrome. I hope you remember, yes, the liver produce the such for like thrombogenicity and like conjugation for conjugative system, yes, for like for to stop hemorrhages. Syndrome of hypersplenism and portal hypertension syndrome. And now we will speak about all of them one by one, and we'll try to remember all possible symptoms. Astenovegetative syndrome, and as I told you already, for viral hepatitis, it's one of the most serious because it's very severe. Fast fatigability, weakness, decreased workforce productivity, emotional instability, nervousness, sleep disorders. Person sleep at day and doesn't sleep at night. Headache, very serious headache, exactly maybe due to such insomnia. Very serious weakness, very quick decreasing of workforce. No, it's really everything present. Dyspeptic syndrome, nausea, poor appetite, heaviness in epigastrium, eructation, bitterness in the mouth, flatulence, and constipation. Sometimes can be diarrhea, sometimes constipation. It's exactly due to the decreasing of bile production, and that's why all changes in the digestive processes. Hemorrhagic syndrome, bleeding gums, nose bleedings, hemorrhage on skin in places of injections. And it's during the already like late stages of the disease, especially during liver cirrhosis. It's really so, and all our patients has such problems with hemorrhages on skin, and there's this in places of injections. Cytolytic syndrome, one of the most important. Why? Because it shows us that cytolysis present. It's like acute cytolysis of hepatocytes, and that's why it's very important syndrome. Clinical signs, what will be, but all these clinical signs as a rule will appear in very late stages. Firstly, will appear the increasing in blood, in biochemistry blood analysis of alanine aminotransferase, and I show here the norm, and here the levels of moderate activity, high activity of viral hepatitis. Also, one another aminotransferase, like aspartate aminotransferase, maybe it's more character for heart, such organ like heart, but for liver also. And you have to remember such meaning like changes of index of this alanine aspartate index, and when aspartate will be higher than alanine aminotransferase, it shows very bad prognosis and show us that already develop fibrosis or even cirrhosis. No? And at the late stages will be body weight decreasing, hemorrhagic diathesis, hepatic smell. Yes, it's a very uncomfortable, such like little like sweet smell, like something like during diabetes. No, but it's not exactly so. It's like if you if you try to feel the smell of rare liver, no, if during cooking, it's something like that. Also present liver tongue. Liver tongue is like very smooth tongue without all this wheelies on the tongue, without it's like very smooth, red and bright tongue. Liver palms will be like very thin skin on the livers and very like even red, we can say. Vascular stars on the skin also sometimes can be seen, but you have to understand that it's exactly mentioned about the liver problems. Modification of body hair, like very weak hair, and sometimes can be gynecomastia because liver also influence on hormone production. Mesenchymal inflammatory syndrome. Clinical signs will be what exactly here present syndromes during acute phase. Fever, arthralgia, because intoxication present. I hope you remember that liver is one of the most important organs and it desintoxicates, yes, all our blood, because through portal vein go all this volume of blood, and liver take off all this and toxins from blood, and it's like the main laboratory of our organism. And if it's under the attack, yes, the liver, all in toxins will stay in our organism and will lead to intoxication and inflammatory syndrome. Vasculitis can be, yes, skin or pulmonary vasculitis, and that's why will be present with such rash on the skin sometimes. Splenomegaly, because yes, sure, no, spleen show us the inflammation. And lymphadenopathy, the same because spleen, lymphatic nodes react on the inflammation. What will be in biochemical blood analysis? Sedimentary samples like thymol probe and sublimate test will be increased, and serum hemoglobulins as a rule will be also increased in comparison with albumins. Cholestatic syndrome, clinical signs. What will be cholestatic? It means that all this bilirubin, all these bile pigments will stay in the skin, in the like our connective tissue, and that's why what will lead to such cholestatic problems like pruritus, skin itching, jaundice. Yes, it's exactly due to the cholestatic syndrome, skin pigmentation, xanthelasma, it's something like such. Yellow plaques on skin, not big, but we can even watch by eye, see by eye. Dark urine, feces lightening. Why? Because it's also present mesenchymal inflammatory syndrome, and that's why not a lot of conjugated bilirubin will appear in the intestine. What will be in laboratory analysis? Gamma glutamyl transpeptidase, one another very important enzymes present in liver, will be increased, especially in the late phases. It will be very high, and also if it's really very high, more than 10 times, it can show us it is not viral hepatitis or maybe autoimmune hepatitis. Alkaline phosphatase, another one enzyme. A lot of enzymes present in liver, you have to understand, but what exactly such will show us the cholestatic syndrome. No, sure, and bilirubin as conjugated as unconjugated. And total cholesterol, yes, sure, it's because it's cholestatic syndrome. No, and as told the Latins, yes, repetitio est mater studiorum. Another one movie, I even don't remember what exactly.
So hepatitis, meaning like this inflammation of the liver, most commonly comes about because of a virus. These viruses tend to target the cells in the liver, right? And when they get in and infect these cells, they tend to cause them to present these weird and abnormal proteins via their MHC class 1 molecules. And at the same time, you've also got these immune cells infiltrating the liver and trying to figure out what's going on. And so the CD8 positive T cells recognize these abnormal proteins as a sign that the cells are pretty much toast. And the hepatocytes then go through cytotoxic killing by the T cells and apoptosis. Hepatocytes undergoing apoptosis are sometimes referred to as councilman bodies, shown on histology here. And this typically takes place in the portal tracts and the lobules of the liver. This cytotoxic killing of the hepatocytes is the main mechanism behind inflammation of the liver, and eventually liver damage in viral hepatitis. As someone's hepatitis progresses, we'll see a couple classic symptoms related to your immune system mounting an attack, like fever, malaise, and nausea. Additionally, though, patients might have hepatomegaly, where their liver is abnormally large from inflammation, which also might cause some pain, right? As more and more damage is done to the liver, the amount of transaminases in their blood will increase. This is because your liver has these transaminase enzymes, so it can do its job of breaking down various amino acids. Typically, the serum aminotransaminase, or the amount in your blood, is pretty low. But when your hepatocytes start getting damaged, they start leaking these into the blood. So a common sign is a greater amount of both alanine aminotransferase, or ALT, and aspartate aminotransferase, or AST. Typically, even though both are elevated, ALT will be greater than AST in viral hepatitis, and it'll also be the last liver enzyme to return to normal. Also, elevated levels of atypical lymphocytes are common to see with viral hepatitis, known as atypical lymphocytosis. The lymphocytes are usually like huge, very large, due to stimulation from antigens, in our case the hepatitis virus antigens. Patients often also end up developing jaundice, with a mix of both conjugated bilirubin and unconjugated bilirubin. The conjugated bilirubin leaks out when bile ductules are damaged or destroyed when the hepatocytes die, because those hepatocytes make up some of its lining. Also, since these hepatocytes are dying, you start to lose the ability to conjugate bilirubin and make it water-soluble, and so you end up with unconjugated bilirubin as well. So since there's both conjugated and unconjugated bilirubin in the blood, some of the water-soluble conjugated bilirubin gets filtered into the urine, giving it this darker color. Another common finding is increased urobilinogen in the urine. Urobilinogen is produced when bilirubin is reduced in the gut by intestinal microbes. Normally, most of that's reabsorbed and transported back to the liver to be converted into bilirubin, or bile again. But if these liver cells aren't working right, that urobilinogen is redirected to the kidneys and excreted, so you end up with more urobilinogen in your urine. If symptoms continue or the virus sticks around for more than 6 months, viral hepatitis goes from being acute to being chronic hepatitis. At this point, inflammation mostly happens in the portal tract, and if inflammation and fibrosis keep happening, we consider that a pretty bad sign, since it might be progressing to post-necrotic cirrhosis. Now, there are 5 known flavors of hepatitis virus that have slightly different and unique properties. Hepatitis A is transmitted through ingestion of contaminated food or water, in other words, the fecal-oral route, and is known to be acquired by travelers. Hepatitis A virus, or HAV for short, is almost always acute, and there is essentially no chronic HAV. If we're talking serological markers, an HAV IgM antibody indicates an active infection, whereas an HAV IgG antibody is a protective antibody that tells us that there's been recovery from HAV or vaccination in the past. Hepatitis E virus is actually pretty similar to HAV, with the same route of transmission, oral fecal, and is most commonly acquired through undercooked seafood or contaminated water. It also doesn't have much of a chronic state, and HEV IgM antibodies tell us that there's an active infection, and HEV IgG antibody is protective and signals recovery, just like HAV. 2 big differences to note, though, between these 2 guys is that, 1, only HAV has the option for immunization, and 2, HEV infection for pregnant women can be very serious and can lead to acute liver failure, also sometimes called fulminant hepatitis. All right, next on the docket is hepatitis C.
Okay, that's all for today. For movie we will not continue because we have to discuss exactly different hepatitis. And now we will start to speak about hepatitis A, type A. Key facts: hepatitis A is a viral liver disease that can cause mild to severe illness. Hepatitis A virus, HAV for shortening, yes, is transmitted through ingestion of contaminated food and water or through direct contact with an infectious person. Almost everyone recovers fully from hepatitis A with a lifelong immunity. However, a very small proportion of people infected with hepatitis A could die from fulminant hepatitis, as I told you at the beginning. The risk of hepatitis A infection is associated with a lack of safe water and poor sanitation and hygiene, such as dirty hands. Epidemics can be explosive and cause substantial economic loss. A safe and effective vaccine is available to prevent hepatitis A. We will speak about this. Safe water supply, food safety, improved sanitation, hand washing, and the hepatitis A vaccine are the most effective ways to combat the disease. Hepatitis A usually spreads when a person unknowingly ingests the virus from objects, food, or drinks contaminated by small, undetected amounts of stool from an infected person. Hepatitis A can also spread from close personal contact with an infected person, such as through sex or caring for someone who is ill. Hepatitis A occurs sporadically and in epidemics worldwide, with a tendency for cyclic recurrences. The hepatitis A virus is one of the most frequent causes of foodborne infections. Epidemics related to contaminated food or water can erupt explosively, such as epidemic in Shanghai in 1988 that affect about 300,000 people. Hepatitis A viruses persist in the environment and can withstand food production processes routinely used to inactivate or control bacterial pathogens. Sure, because it's virus. Here you can see the geographical distribution of hepatitis A infection. You see, worldwide, yes. Some were lower, some were high morbidity, but all the world is involved. Так, about etiological factor, about exactly the virus. HIV is a single-stranded positive sense linear RNA enterovirus of the P. coronavirus family. It is non-enveloped and contains a single-stranded RNA packaged in a protein shell. There is only one serotype of the virus, but multiple genotypes exist. Hepatitis A virions were first identified in the stool of patients by electron microscopy in 1973. How long can hepatitis A virus survive outside of the body? Hepatitis A virus is able to survive outside the body for months. High temperatures such as boiling or cooking food or liquids for at least 1 minute at 85 degrees by Celsius kill the virus. Also freezing temperature do not. Freezing no. What you can see, yes, the risk factors: poor sanitation, lack of safe water, use of recreational drugs also, what for example, living in a household with an infected person, being a sexual partner for someone, traveling to areas of high endemicity without previous immunization. Symptoms, very quickly, the incubation period is usually from 7 to 45 days. Yes, the incubation period can be very long. Don't forget about this. Even till 45 days, like half and half a month. Fever, fatigue, loss of appetite, nausea, vomiting, abdominal pain, dark urine, diarrhea, clay-colored stool, joint pain, jaundice, yellowing of the skin and eyes. Here you can see. Diagnosis. Acute infection is documented by the presence of immunoglobulin M, IgM, anti-HAV, which disappears several months after the initial infection. What you can see, yes, this red, immunoglobulin M against HAV. It appears even on the first days after the infection, maybe not after the infection, after the beginning of the disease, even during the prodromal period, before clinical, some days before clinical manifestation. The presence of immunoglobulin G, IgG, anti-HAV demonstrates that an individual has been infected with HIV in the past, from 2 months ago to decades, even decades, years ago. What you see. And this marker, yes, IgG anti-HAV, can stay long life. IgG anti-HAV appears to offer patients lifelong immunity against recurrent HIV infections. During the acute stage of the infection, the liver enzyme alanine aminotransferase, what you can see, the blue line, is present in the blood at levels much higher than normal. The enzyme comes from the liver cells that have been damaged by the virus. Hepatitis A virus is present as in blood, as in feces. In blood, maybe a little earlier. You see, viremia, yes, viremia, and in feces, HIV in feces. Up to 2 weeks, you see, before clinical manifestation. Treatment. As a rule, treatment of acute HIV viral infection is supportive because no antiviral therapy is available and not needed as a rule. Hospitalization is needed for patients with nausea and vomiting and risk of dehydration and sometimes even fulminant hepatitis. Patients with acute liver failure require close monitoring to ensure they do not develop fulminant hepatic failure. There is no specific treatment for hepatitis A. Patients are advised to rest, avoid fatty foods, take diet and alcohol. This may be poorly tolerated for some additional months during the recovery phase and cause minor relapses. Eat a well-balanced diet and be hydrated. Drink a lot. Prevention of HIV infection, as I told you, we would speak about this, but now we are speaking. And such like vaccine present, like Covrix, it's exactly for children. Since 2006, the CDC has recommended vaccination for all children at 1 year of age. Now, as a rule, it's recommended for developed countries. It has encouraged catch-up vaccination programs for unvaccinated children, exactly against hepatitis A, or maybe in some epidemiological directions, if you were in contact or something like that, or are going to visit the endemic regions. Other groups of individuals who should be vaccinated include persons with an occupational risk, yes, persons working with HIV-infected primates, recipients of clotting factor concentrates, persons who are either waiting or have received liver transplant, patients with chronic liver disease, although not at increased risk for exposure to HIV. What is the risk? Increased risk of fulminant hepatic failure if they would be infected by HIV. And some words about hepatitis E, because it's also fecal oral hepatitis. That's why we have to remember about this possibility. Key facts. Hepatitis E is a liver disease caused by infection with the virus known as hepatitis E virus, HEV. Every year, there are an estimated 20 million HEV infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis E. World Health Organization estimates that hepatitis E caused approximately 44,000 deaths in 2015, accounting for 3.3% of the mortality due to viral hepatitis. It's very high indexes. The virus is transmitted via the fecal oral route, principally via contaminated water. It's the main, like diluted of small amount of stool, yes. Hepatitis E is found worldwide, but the prevalence is highest in East and South Asia. Now I will show you. A vaccine to prevent hepatitis E virus infection has been developed and is licensed in China, but not available for another countries. So here you can see the prevalences, yes. It's something like, looks like tropical, but not such distribution, but can be all over the world. You have to understand it's not needed very high temperatures or something like that, but the prevalence, what exactly in such regions. Key facts. Hepatitis E is a liver disease caused by the hepatitis E virus, a small, spherical, non-enveloped virus with a positive sense single-stranded ribonucleic acid RNA genome calicivirus. The virus has at least 4 different types. Genotypes 1, 2, 3, and 4. Genotypes 1 and 2 have been found only in humans, but 3 and 4 also circulate between animals, including pigs, wild boars, and deers, without causing any disease, and occasionally infect humans. Similar to hepatitis A pathogenesis, virus replicates in the gut initially before invading the liver, and virus is shed into the stool prior to the onset of symptoms. Viremia is transient and very short. Complications can be fulminant hepatitis in pregnant women. Nobody knows till now why exactly for pregnant women so dangerous. Mortality rate in pregnant women is very high, up to 40%. Here you can see also it's like the same like for hepatitis A. Yes, virus in stool present, viremia also here not present. Alanine aminotransferase very high. Immunoglobulin A appear on the, for example, on the second week of the disease, in the climax on the 6th week of the, like about months after the starting of clinical, of prodromal period symptoms, and also immune IgG anti-HEV will stay also a long life. No routine laboratory tests are available as yet. Virus cannot be cultured in vitro. That's why it's interesting and hard for investigation. Calicivirus-like particles in stool by electron microscopy. Specific IgM, polymerase chain reaction, HEV specific sequences in stool. And for today, that's all. We will continue next lecture. We will speak about B, C, D hepatitis, and maybe you have questions. Students, do you have questions?